Hey, everybody. Thanks for joining us today. I have Dr. Eric Johnson here with me today. He's the medical director of a diabetes center in North Dakota. He's the president of the American Diabetes Association of North Dakota, and he is the chair primary advisory committee. Is that right? On the American Diabetes Association?
Yes, that's correct.
Okay. Thank you so much for joining us. And dealing with my technology issues, which is awesome. I really, really appreciate it.
Well, thanks, Dr. Flexer.
Yeah. So we are going to talk about diabetes in terms of like people talking to people in the community, other clinicians out there that work with these folks, and hopefully bring some awareness and some new ideas and just general understanding of diabetes. So you tell us a little bit about your um, work with diabetes.
Sure. I actually have type 1 diabetes. That's kind of how I got all started with this. That's the kind of diabetes typically associated with onset in childhood, but I actually got it as an adult. I have been working in diabetes care for about 30 years here in North Dakota, where I'm the assistant medical director of a diabetes clinic here in Grand Forks, North Dakota at Altru Health System. Um, Diabetes is a really huge topic right now. When I started working in diabetes care back in the late 80s, early 90s, there were about 15 million people in the United States with diabetes, but now there's almost 31 million people with diabetes, and about 90% of those are type 2, which is typically adult onset, usually associated with obesity or sedentary lifestyle, but sometimes is strongly associated with family history.
So would you attribute that rise to like correlating it with the rise in obesity as well that we have in our country right now, or what would you attribute that to?
Yeah, I think so. That is certainly one of the biggest risk factors for the development of type 2 diabetes, along with sedentary lifestyle and poor diet. What basically happens, one of the central features in type 2 diabetes, is those people are still making insulin from their own pancreas, but their body just doesn't know what to do with it. That's quite different than type 1 diabetes, where the pancreas just stops making insulin. And there are no known risk factors or prevention factors for type 1. But for type 2, we know that improved lifestyle can reduce the risk of type 2 diabetes by 58%. And that includes things like 150 minutes of exercise per week, losing 7% of body weight, and other lifestyle adjustments.
So what is the difference? Like we hear controlled and uncontrolled. Is that what does that mean when someone is controlled diabetic?
Well, people with good diabetes control typically have a lab value called the A1C, which is would typically be less than 7. And this would be less than a daily average of blood sugar of 154. If you were checking blood sugar throughout the day at various times, we would take the average, and typically it would be less than that number. Now, we're not just chasing numbers when we're treating diabetes. These numbers actually have meaning. We know with people who have elevated A1Cs, starting at about 7, 7.5, somewhere in that range, we start to see a pretty significant increase in complications. That includes things like nerve damage, typically in the feet and legs, blood vessel disease in the legs, heart attack, stroke, kidney disease, and eye disease.
So is that this are the risk factors the same for someone that's type 1 and type 2 if they're not controlled?
Yeah, some of the same things happen. They start out looking a little bit different, but by the end, they have a lot of similar features with respect to complication profiles. Eventually, most type 2 patients are going to need to be on an insulin product because slowly their pancreas will make less and less insulin all the time. And typically, those patients aren't hard to figure out. They've had diabetes longer than 8 or 10 years, and their A1C would be over 9. that would tell us as clinicians that they're probably not making a lot of their own insulin anymore.
So even if someone had been controlled and doing a good job for a long time, like with the diet and the lifestyle, if they fall off that wagon, they run the risk of having these complications at any point.
Yeah, they certainly do. And in my practice, I have seen a lot of complications over the years in pretty good numbers. There are some people who do a spectacular job with their diabetes. They have very few problems going forward. As they age, they're a little bit more likely to start developing complications just because they've had diabetes a really long time. But kind of the magic number, I think most clinicians would agree that after about 15 years or so, that's when we really start to see an acceleration in complication rates. And we would see sooner and more of those in people with diabetes control that's less than ideal.
Okay. So, like, I'm a physical therapist. I see people for different reasons, let's say, that they're not coming to me for their medication management, but they're showing up for mobility issues.
Yeah.
And a lot of times it seems, if you're not, unfortunately, diabetes is so prevalent that it's almost one of those comorbidities that you just kind of overlook because it's like just another thing in their chart.
Yeah.
How can we be an advocate for these folks?
Well, I think if we're looking at the intersection with physical therapy, that can be really critical for a lot of patients. A lot of people, it's important with diabetes, whether you have type 1 or type 2, to be active. But if you have some kind of functional limitation, like maybe you have osteoarthritis of your knees or hips, maybe you have some other mobility problems stemming from another issue, like maybe a stroke. Um, getting moving again is really helpful for those patients, because when their activity level falls off, they really start to struggle with this typically.
Yeah, we see it sometimes with like total knees or total hips that maybe don't recover as fast or the wounds don't close as well. How does diabetes affect the skin? And
Yeah, diabetic wounds are really difficult. Surgical healing is often delayed, even in people with really good diabetes control, but people with poor diabetes control have wounds that sometimes don't heal. I'm sure you've seen those on occasion.
yeah,
Really aggressive wound treatment can help quite a bit. It's really a multifactorial thing that causes wound issues in diabetes. And it's kind of a combination of nerve damage, which we call neuropathy, and vascular damage in the legs. And that can be in large vessels or in small vessels. But you start getting impaired circulation combined with neuropathy. Skin breakdown is a very common issue. That can be from pressure. That can just be from poor circulation in a given area. Those are kind of classic diabetic foot ulcers. And there's other things that are happening at the level of the skin that contribute to poor healing. In diabetes, white blood cells, which are responsible for a lot of our immune response, don't function as well in the bloodstream and in tissues. So that's another factor why wound healing is often impaired.
and that can even be it might not even be like the classic diabetic foot ulcer where it's on the bottom of the foot, but it could be affecting any wound that they get. Like it could
Oh,
be a friction, like they new shoes and it rubs, or that surgical incision that they had for another reason. And it can
no,
affect how quickly it heals. The wound can dehisce.
yeah, it certainly can. And if you pile on infection on top of this poor wound healing, that's when it really gets into trouble very quickly. I have seen some infections really get out of hand in very short order, and patients need to know what to look for. If they have a wound that's not healing, a wound that becomes red or painful, but it may not if they have nerve damage, and
Yep.
any kind of drainage, those are all red flags, and we need to take notice. Part of our comprehensive approach here is like what you do. We have wound care that is very dedicated for that. And I call on those guys a lot in these particular issues. We don't want to forget about traumatic injuries either. We have a lot of agricultural people who work in agriculture in our area, and they get slammed by a piece of metal on a piece of equipment, or they have a fall. Um, those wounds can really be problematic as well, like a cut on the leg, for example.
Yeah. And I tend to see folks almost like not getting care quick enough. Like they try to take care of it at home with like DIYing their wound and using whatever there is. But especially if you have diabetes and you have a traumatic injury, like you need to get some medical care quickly.
Yeah, yeah, kind of our general guideline, and you probably tell people something like this when you're seeing them, that if they're not seeing improvement in 3 to 5 days or maybe a week, they really need to be seen or seen again. And that's kind of where we go with it. Really, any change in status is something that we want to evaluate. Some of those we can do by video visits. They don't necessarily have to come to the clinic. We're expanding telehealth all the time, like everybody is. And that's actually pretty good for wound care.
Yeah, I love it. I love when people are like, you can't help a wound from a picture. I'm like, yes, you can.
Yeah, sure can.
You sure can. You definitely know if like it's not right. Like whatever they're doing is not right. So how does infection set in different for someone who has the diabetes?
Yeah, it really does. We see a lot of the same bacteria, but sometimes we see bacteria that are less common just because people with diabetes have mild immunity impairment, and they
Okay.
just don't stave off infection as well for a lot of reasons. I talked about those white blood cells don't function quite right, but other healing factors and processes are also mildly impaired, and all of those things add up to difficulty. Ideally, we want to have a culture of any wound so that we can identify the specific bacteria. Now, quite often they're strep or staph species, but some of those staph are drug resistant. I think most people have probably heard of MRSA by now,
Hmm.
methicillin resistant Staph aureus. We see a fair amount of that. But sometimes we see other bacteria that are much less common, like Pseudomonas, for example. And getting the right diagnosis is important for choosing the right antibiotic and the right path for wound treatment.
That we weren't planning to talk about this, but so I will see folks come in for their wound, right? And they get on an IV antibiotic, but then they're kind of perplexed why it's not working fast enough, right? Like they need a couple of courses, but that all makes sense, right? Like the blood flow is diminished, the circulate, like just everything is diminished to that area, and we're talking about a distal foot wound.
Right.
Like the antibiotic is gonna take even longer to get there, or it might never reach there, right?
Yeah, I'm glad you're bringing that up because that's a problem, particularly with small vessel disease. The further you get down the leg and out into the foot, you're talking about smaller and smaller and smaller blood vessels. And basically, those get clogged up or fail. And
Yeah,
then the antibiotic has a hard time penetrating the tissue.
yeah.
That can really be an issue. You're exactly right. I'm glad you brought that up.
And then we'll use, topical antimicrobials to kind of hit it from both ends. Something we see a lot in the hospital, and there's always like a little bit of controversy over it, is like weight bearing status,
Yeah.
right? Right, like we have these foot wounds, and if we're talking about it in terms of obesity and mobility and stuff like that, making someone not weight bearing on a foot can mean like not moving,
Yeah.
and which is not helping anything, but it always becomes a little bit of a difficulty, like how do we get people moving and home. And
Yeah. And physical therapy is huge in this role. Sometimes we'll get a personal trainer involved. But you're right. One of the cornerstones of wound treatment in feet is mechanical offloading. And that's
Mhm.
just limiting the use of that area or wearing a specific cast or boot to reduce pressure on that wound, and that can really affect mobility. So we have to be clever about it. We have to think maybe more about a bike or maybe some upper arm type stuff, upper body stuff. And it's really irresponsible for me as a physician to tell somebody with a foot wound to increase their activity by walking more.
Yeah.
That's not a good choice. We need to be more sophisticated than that.
Yeah. And I would like to say crutches probably aren't like the best
No.
mobility. Like we see that all the time, like a recommendation for crutches, and we're like, they're 80, like, or
Right.
like,
Yeah.
is that okay if I change that, to something that actually works for the person, however we can get them moving.
Yeah. We need to really fine tune these approaches to make sure we're doing the right thing. And yeah, I mean, crutches in most 80-year-olds is a prescription for a fall, and then you have lots of other problems. And
Right.
people
Or just,
with, people with diabetes have higher fall risk too as they age. So we need to think about these things.
yeah. So, yeah, diabetes and foot wounds and all that is a huge factor with amputations, and then not, the wound not healing and needing to have an amputation. I know lots of people are afraid of that and maybe aren't getting care because they don't want to get that kind of news.
Yeah, I'm amazed how long some people will go with a non-healing wound,
Yeah.
and then by the time we see them, it's just beyond repair. I've had people show up in the clinic with necrotic toes, which is basically completely dead tissue,
Mhm.
um, or even the toe coming off in the sock painlessly because they have so much nerve damage. It can really be extreme like that. And wounds themselves account for about 20% of all diabetic hospitalizations. I think we think about high blood sugar and low blood sugar, or maybe kidney problems, or pneumonia, or some other infection. But this is a good chunk of hospitalizations. And probably half of all amputations in the United States are diabetes related. So it still happens. Even though the numbers have declined in the last 20 years, that doesn't mean there's not a lot of it.
Yeah. Yeah. We see it all the time. And then it just, they come in for surgery, the surgery doesn't go well, and it's just repetitive.
Well, then you're
Um,
looking at a surgical wound that doesn't want to heal either.
yeah, yeah, it's a problem. Um, is there any new research like on the home front of healing wounds or getting them to close? And
Yeah, it's not all bad. I mean, we have a lot of things we can do to help heal wounds. And I know at our wound clinic, I send things to them that I think, wow, they're never going to be able to fix this. And they actually get better. There's a number of topicals. They use a lot of colloids. They do a lot of mechanical and surgical, um, where they kind of remove the dead tissue.
mhm,
Um, they do a number of things like this and a lot of those things will work. Debridement is still a standby, and that's a very old way of treating a wound. But there's lots of ways to do that. There's even biological debridement now, where sterile maggots are used,
yeah,
which sounds really bizarre and kind of 14th century, but actually that works pretty well for certain wounds. As far as on the research front, a lot of effort is being put in right now to skin cultures, where you're actually growing skin in the lab. And that can be from a variety of sources. Recently, I had a conversation with one of our wound clinic guys, and he said there's some work around placental tissue for skin cultures, as well as neonatal foreskins, as wild as that sounds. But sources for skin culture in the lab is really kind of a hot area right now in wound.
okay. Um, so I'm thinking from what we're saying, I'm hearing like the best advice we could give people is to check their feet, like look at their feet, right?
Yeah.
Get, if you notice anything, any changes, to get care right away.
Yep.
What kind of specialists do you recommend for people to be in contact with?
Yeah. I think you're right. Some of this starts at home. daily foot inspection. If you're visually impaired, which is common in diabetes too, and you're unable to do that, you need to have somebody in your household who can do it, or a place that does that regularly. For example, for older people in our community, they can go to the senior center, get nail care for a modest price, and have their feet inspected. So that's where it all starts. Um, there's a couple of directions you can go with a foot wound. I think the initial treatment is often with a podiatrist who's a foot specialist or a wound care clinic. And we can go either of those directions here.
Mm-hmm.
Quite often we go in the direction where they can be seen first because it's very likely they're going to need to be seen in both of those offices.
Right.
And then if they have some other issues like with functionality, they might end up with somebody like you in physical therapy. There's a lot of ways that can go, and they kind of all converge.
Mm-hmm.
Um, Team management is critical with this. We talk about team management all the time in healthcare, but this is an area where it actually, when it functions very well. And you can reduce amputations by about half with good team-based care for the wound.
So their team, like for somebody should, if you have diabetes in your home and you're hearing this, like you should have a good podiatrist, a foot specialist. You should be in touch with your local wound center, or at least like know how to get in touch with them.
Yeah, and
Yeah.
if you don't know how to do that, ask your primary care provider,
Mm-hmm.
whoever that is, be it a physician, NP, PA, wherever you go, or where you seek diabetes care if you're seeing a specialist. I know in our office, in our diabetes center, we know everybody who you should go to.
Right.
But I don't
Okay.
expect patients to necessarily know that. They might, but if they don't, they need to ask the right person to get them going with that.
And I know the American Diabetes Association website has a ton of information.
Yeah, that's a good page, diabetes.org.
Okay.
That's a really good page. The American Podiatry Association has some pretty good information. And actually, WebMD and Medscape are pretty good consumer sites too. So those are places where you can get started.
Mm-hmm.
And I think that's a pretty good way to go. And more, we're seeing people like you with a background in physical therapy getting involved with this as well.
Yeah, I want more PTs to not be scared of wounds and really like
Yeah,
if you're in PT for something, mobility related, maybe it's not for your foot wound or for your like you can ask your therapist to take a peek at your foot if something's been bothering you or you're not sure, like your socks wet or you
yeah,
got new shoes or like something's off, you can always ask your therapist to peek for you and get an eye on things. They have access to
yeah,
people and community, like if whoever you're seeking care from should be able to like point you in some kind of direction.
yeah,
And
absolutely.
doesn't the American Diabetes Association recommend annual foot checks?
Yeah, the current recommendation with the current guidelines, which are updated annually, is you should have a visual inspection of your feet at every visit for your diabetes, which would be 2 to 4 times a year, or when you have a status change.
Mm-hmm.
And then
And
a
they're
complete full exam would be once a year, and that's where they test your nerve function and all that.
Yeah, I was gonna say they look for like sensation and all
Yeah,
that.
yeah.
Right. Yeah. Perfect. Anything else we want to share with the folks?
Yeah, I think people need to know that a lot of this is preventable. And if they're doing a good job with their diabetes now, it's far less likely if they'll have trouble down the road. The statistics on all this has been worked out for quite some time. Some of the studies that have looked at this are going on 40 years old,
Mm-hmm.
which is an extraordinary length of time for any medical study. So those people tend to do better. If you're having problems, seek care sooner and follow directions and keep your follow-up appointments.
Absolutely. Yeah. And if you have any questions, if you have a wound that you're having a hard time with, you can feel free to reach out to me at betterwounds and betterwounds@gmail.com. I can get in touch with anyone or at least point you in the right direction and get you some resources and help you feel more confident and comfortable with what's going on. All right. Thank you so much, Dr. Johnson. I
Uh,
appreciate it.
yeah, thanks, Dr. Flexer.